Welcome to the Australian Dental Council Explainer podcast.
Yeah, we are jumping right into the deep end today.
Welcome to the Australian Dental Council 2026 Clinical Explainer. Today we're doing a high-yield deep dive into two things ADC candidates must nail: the exam pathway and clinical safety for medically compromised patients, including anaphylaxis emergency management and long-term considerations like chronic kidney disease, plus what updated therapeutic guidance says about systemic conditions such as obesity and liver failure.
Right, and I mean, this is specifically for you, whether you are an ADC candidate, navigating that rigorous examination process, or you're a clinician calibrating your approach for safe practice in Australia.
Exactly. We are covering the actual architecture of the exam itself, plus the real-world medical risk management that you are definitely going to see in those MCQs or the OSCE-style reasoning scenarios, and obviously on the actual clinic floor.
Because that transition from theoretical knowledge to clinical application, well, that is the entire philosophy behind the ADC examination pathway.
Yeah, it really is.
Before you can manage a systemic crisis in an Australian dental chair, you have to pass through this specific gatekeeper. The framework is there to prove that overseas qualified practitioners have the clinical judgment required for the Australian healthcare system.
And the initial threshold to even get assessed is, well, it's incredibly rigid. I mean, you are required to hold a 4-year full-time university dental degree or diploma from a recognized institution.
Right. A recognized institution is key there.
Yeah. And beyond the degree, you have to currently hold a full, unrestricted license in your home country or the country where you trained. Plus, the documentation explicitly mandates that there can be zero history of withdrawals or suspensions on your registration.
None at all. And the administrative phase, after you establish that eligibility, is it's equally stringent. Candidates have to create an ADC Connect account and undergo the initial assessment.
Which takes a while, right?
Yeah, it typically takes about 8 weeks.
Yeah.
And crucially, this requires meeting the revised March 2025 English proficiency standards.
Oh, right, the new standards.
Yeah, exactly. The accepted pathways for this are Cambridge, IELTS, OIT, PTE, or TOEFL.
But, let's highlight a massive administrative trap here that consistently derails candidates. The official guidance places a really heavy emphasis on assessment deadlines, but just clicking submit before midnight on the due date, that does not secure your seat for the written exam.
It really doesn't. Submitting the initial application by the deadline offers zero guarantee of examination eligibility. Like, none.
Wow.
Yeah, because incomplete applications immediately trigger a request for additional documents. And that back-and-forth communication, it takes time. During that delay, your application simply might not be assessed in time for your target examination period.
Right, so it's like getting your passport stamped. Just being in line at the airport terminal doesn't mean you actually make the flight.
That is a perfect way to look at it.
If your paperwork is missing a single page, you are basically pulled out of the boarding line. And this is a plane that only leaves during specific testing windows, so you're just left on the ground until the next cycle.
Exactly. Meticulous attention to detail is required before you even, look at the syllabus. But speaking of the syllabus, the blueprint for the 2025-2026 examination period reflects a very structured approach.
Okay, let's unpack this. How is it structured?
So it evaluates candidates across 4 primary domains. You have professionalism and health promotion, then clinical information gathering, diagnosis and management planning, and finally, clinical treatment and evaluation.
Okay, 4 domains. But within those, there are 2 heavily weighted subdisciplines that really dictate a massive portion of your study strategy, right?
Oh, absolutely.
Yeah.
Pharmacology constitutes 10% of the exam, and implants make up 4%.
10% just on pharmacology alone. I mean, that is a very clear signal from the ADC.
It signals the absolute end of rote memorization as a viable study tactic. Like memorizing isolated drug classes or standalone side effects, it will not help you here.
Because of the test format.
Right. The 2025-2026 written exam is a computer-based test, a CBT, and it's comprised entirely of scenario-based MCQs.
Entirely scenario-based.
Entirely. We're looking at 240 scored questions and 40 unscored validation questions, all of them embedded in complex clinical vignettes.
Wait, so why exactly did the ADC shift to entirely scenario-based questions? Why not just test the core knowledge?
Well, according to the sources, it simulates the complex multifactorial decision-making in a real Australian clinic. It moves completely away from just memorizing drug classes, because, clinical practice isn't just about knowing a drug's name.
Right. I mean, that shift makes perfect sense when you consider clinical reality. You aren't treating a floating tooth in a vacuum. You are treating a patient with a complex medical history, an existing pharmacotherapy regimen, and intersecting socioeconomic factors.
Exactly.
A routine visit can escalate into a systemic crisis just because of a single oversight, which actually brings us directly to the most severe, immediate crisis you can face in the chair, which is anaphylaxis.
Yeah, anaphylaxis is really the ultimate test of that multifactorial decision-making under extreme pressure. It is a severe, life-threatening type 1 hypersensitivity reaction.
And in the dental setting, the triggers are basically everywhere.
They are ubiquitous. The guidelines specifically identify latex, antibiotics, and certain local anesthetics as high-risk culprits.
So recognizing it instantly is essentially the only way to prevent a fatality. And we aren't just talking about someone feeling faint or having a standard visivagal syncope, right? Which, usually just presents with pallor and bradycardia.
No, not at all. The clinical signs of anaphylaxis outlined in the ACA guidelines are distinct and aggressive. You are monitoring for a puerperal rash, significant swelling of the lips and tongue, and facial flushing paired with clammy skin.
That sounds terrifying.
It is. And on the respiratory side, airway constriction produces an expiratory wheeze or stridor. Plus, cardiovascularly, the patient experiences a profound drop in blood pressure, which frequently leads to syncope.
Okay, so the moment you observe that specific cascade, the flushing, the stridor, or the sudden hypotensive collapse, what is the immediate clinical sequence? Because hesitation in an OSCE station or a real clinic is an automatic failure.
Step 1. Cease dental treatment instantly. Step 2. Call 00 to dispatch an ambulance.
Right. And then posture matters a lot here, doesn't it?
It is critical. The patient must be laid flat immediately. You cannot allow an anaphylactic patient to stand or walk because the profound vasodilation severely compromises venous return to the heart. It can actually be fatal.
Wow, okay. Are there any exceptions to lying them flat?
The only exception noted in the guidelines is for respiratory distress. If the patient is struggling to breathe, you can allow them to sit up slightly to maintain airway patency, but they must remain seated. And finally, if you're equipped, deliver high-flow oxygen at 15 liters per minute.
And then we reach the definitive pharmacological intervention.
Yeah.
We have to administer intramuscular adrenaline.
Exactly.
Yeah.
And the dosing arithmetic must be automatic. For adults and children, the dose is 0.01 milligrams per kilogram, capped at a maximum of 0.5 milligrams.
Okay, so practically, for an adult, what does that look like?
That equates to 0.5 milliliters of a 1.1000 adrenaline solution. But preloaded auto-injectors, like EpiPens, they typically contain a 300 microgram dose.
Which is 0.3 milligrams.
Right.
Okay, and the guidelines are very specific about where this intramuscular adrenaline goes. The anterolateral aspect of the thigh is the standard recommendation, but the documentation explicitly states you can also inject directly into the tongue or the floor of the mouth.
Yes, it does.
Here's where it gets really interesting. Injecting into the floor of the mouth sounds incredibly extreme for a general dental setting. Like, why would we bypass the thigh for the oral cavity?
Well, you have to consider the mechanism of anaphylaxis and the pharmacodynamics of the drug. The patient is experiencing massive vasodilation and severe bronchoconstriction, right?
Right.
So adrenaline acts on alpha-1 receptors to force vasoconstriction, which rapidly restores blood pressure, and acts on beta-2 receptors to trigger bronchodilation, opening the airway. In a life-and-death scenario where the airway is actively closing, you require the fastest possible absorption into the systemic circulation. The tongue and the floor of the mouth are exceptionally vascular. So, per the guidelines, if the thigh is inaccessible or you need immediate localized absorption near the compromised airway, you utilize the most vascular site available.
That makes total sense, but it is intense. Now, 5 minutes feels like an absolute eternity when a patient isn't breathing. If that initial dose doesn't break the hypersensitivity reaction, I'm assuming we don't just stand there waiting for the paramedics. We escalate.
Absolutely. If there is no improvement, you repeat the dose after 5 minutes. Continuous monitoring of the airway, breathing, and circulation is mandatory, and you have to verify that hospital transport is en route.
And if the worst happens?
If cardiac arrest occurs, CPR must be initiated immediately.
This entire protocol really underscores the gravity of medical emergencies in the chair. And we must be explicitly clear for anyone utilizing this material. This overview is educational and must be used alongside current local emergency protocols and clinical judgment.
For sure. Managing an acute crisis like anaphylaxis demands rapid, flawless execution. If we connect this to the bigger picture, the foundational philosophy of the ADC syllabus, and safe practice in general, is that the most effective way to manage a medical crisis is to prevent it entirely.
Yes, preventing it before it even starts.
Exactly. And prevention relies entirely on meticulous care planning and rigorous health history reviews.
It's the clinical detective work you do before you ever pick up a handpiece. A thorough health history review isn't just a passive glance at a standard intake form. You really must actively confirm pregnancy status, because that fundamentally alters prescribing parameters and radiographic protocols.
Right, you can't just assume.
No. And you have to comprehensively assess their cardiovascular history. Also, tying back to our anaphylaxis discussion, you must heavily scrutinize antimicrobial hypersensitivities.
The guidelines actually place particular emphasis on differentiating the severity of those hypersensitivities. Practitioners have to distinguish between a non-severe penicillin allergy, perhaps a mild localized rash reported a decade ago, and a severe penicillin allergy involving a history of anaphylaxis or severe systemic involvement.
That distinction is huge. And the sources also explicitly flag several other critical risk indicators. You are required to evaluate periprocedural bleeding risks, identify patients at risk for infective endocarditis, assess the potential for surgical site infections, and monitor for the risk of an adrenal crisis.
Especially in patients managed on long-term corticosteroids.
Yeah.
And that level of systemic evaluation, it seamlessly introduces one of the most complex chronic conditions outlined in the materials, which is chronic kidney disease, or CKD.
Right, because the kidneys are the primary filtration system for metabolic waste, and they play a central role in the pharmacokinetics of numerous drugs prescribed in dentistry.
Exactly. The guidelines categorize CKD into stages 1 through 5, and this is driven primarily by two essential pathology markers. First is the eGFR, or estimated glomerular filtration rate, which measures the functional flow through the kidneys.
And the second one?
The ACR, the albumin to creatinine ratio. This measures protein leakage into the urine, which is a key indicator of glomerular damage. So stage 1 indicates normal filtration but with underlying structural damage, and it progresses down to stage 5, which is defined as an eGFR of less than 15, signifying kidney failure.
The clinical implications of that declining eGFR, they extend far beyond just altered drug clearance. CKD initiates severe systemic physiological shifts. Like, as renal function deteriorates, the kidneys fail to convert vitamin D into its active form.
Right, impaired vitamin D activation.
Yeah, and this impairment directly disrupts calcium and phosphorus homeostasis, which leads to profound bone and mineralization disorders.
And we also have to consider the respiratory comorbidities. The sources specifically highlight an incredibly high prevalence of obstructive sleep apnea, or OSA, in this demographic.
Oh, wow. How high?
OSA affects up to 50% of people with an eGFR of less than 15.
Half of them. That is a staggering comorbidity rate.
It is, and it is identified as a significant driver of refractory hypertension in these patients. So managing a patient with refractory hypertension, impaired bone mineralization, and compromised renal clearance, it creates a pharmacological minefield.
Yeah, no kidding.
This introduces a critical hazard detailed in the text known as the triple whammy.
But triple whammy, it is a terrifying scenario because it often stems from a seemingly innocent dental prescription. It happens when a patient is already managed on a combination of an ACE inhibitor or an ARB, which are standard antihypertensives, alongside a diuretic.
Right, that's two parts of the whammy.
And then the dentist prescribes an NSAID or a COX-2 inhibitor, like ibuprofen, for routine postoperative pain.
And that specific triad of medications can precipitate an acute kidney injury. To understand why, you just have to look at the hemodynamics of the glomerulus. The ACE inhibitor is already dilating the efferent arteriole to lower blood pressure, and the diuretic is reducing overall blood volume.
So the system is already strained.
Exactly. When you introduce an NSAID, it inhibits prostaglandins, which forcefully constricts the afferent arteriole, the main vessel feeding blood into the kidney.
Let's visualize that mechanism for a second. Think of the kidneys like a coffee filter operating under pressure. The triple whammy is essentially crimping the water hose feeding the machine while simultaneously opening the drain valve at the bottom, all while the internal pump is running dry.
That is a great analogy. The filtration pressure collapses entirely, and the kidney basically shuts down.
And that acute hemodynamic collapse is precisely why pharmacology carries a 10% weight on the exam. You must aggressively manage medication dosages based on renal function.
You really have to. For example, The dosage of medications like metformin must be actively reduced in correlation with the patient's creatinine clearance, or CRCL. Standard dosing protocols are completely obsolete once you drop into the lower stages of CKD.
So we have thoroughly covered the pharmacological and systemic management of CKD, but a logical question for a restorative dentist would be, how does this impact the actual physical materials we use? Like, are there specific modifications to restorative dental materials required for CKD patients?
That is a really fair question.
For instance, do we need to avoid specific composites or cements due to those mineralization issues we talked about?
Well, based strictly on the provided documents, that is unknown, not in the record. The explicit focus of the text remains entirely on physiological and pharmacological management, not the physical dental materials.
Right. The evidence provided just doesn't cover it. And patient safety frameworks evolve constantly, Which brings us to the latest structural updates in clinical governance.
The therapeutic guidelines, right? Yes. The therapeutic guidelines. Oral and Dental version 4 has introduced significant modifications compared to the baseline guidelines.
And staying current with these therapeutic guidelines isn't just about passing the ADC exam, it's the absolute baseline for legal and ethical practice. So, what specific architecture changed in version 4?
The most notable updates in the new version include expanded content and entirely new printable flowcharts, specifically addressing treatment planning considerations for obesity and liver failure.
So those are new additions compared to the baseline?
Yes, completely new. Additionally, the guidelines expand on the management of patients with cancer and cognitive disability, which is also really vital.
But those structured step-by-step flowcharts for obesity and liver failure, that represents entirely new territory compared to the baseline guidelines. It reflects a much broader clinical recognition of how systemic diseases dictate dental treatment parameters.
It demands a highly integrated approach. So what does this all mean for a dentist prescribing a simple painkiller?
Yeah, that's exactly the question. What does it mean?
Well, the triple whammy proves it perfectly. If a patient presents with liver failure or complex CKD, you aren't just dealing with a localized dental issue. You are navigating altered metabolism of local anesthetics, potential coagulopathies, severe drug interactions. Dentistry is no longer just about teeth. It requires comprehensive systemic pharmacology.
Absolutely. The addition of these flowcharts ensures practitioners have a standardized, evidence-based pathway for managing these complex systemic variables safely.
Exactly.
Integrating everything we've discussed, the complex CBP scenarios, the immediate life-saving interventions for anaphylaxis, the physiological depth of CKD management, and the new therapeutic flowcharts. It fundamentally reframes the modern dental profession. You are no longer just treating teeth in isolation.
This raises an important question for candidates to consider as they prepare. With an increasingly aging population managing complex multi-drug regimens, the traditional boundary separating dental surgery from general medicine is dissolving.
It really is.
Are modern dental professionals actually becoming systemic risk managers who just happen to operate in the mouth?
That is an incredibly powerful paradigm shift to keep in mind as you study. You are training to keep a medically complex human being safe in your chair while delivering specialized care.
Well said.
Thank you for joining us on this deep dive into the clinical safety essentials. Please follow and subscribe to the show so you never miss an explainer. For your own preparation, ensure you directly reference the sources we utilized today: the official ADC handbooks, the ASIA guidelines for acute anaphylaxis management, and the updated therapeutic guidelines version 4.
Yeah, definitely read through those.
If you have questions about the mechanisms we discussed, or if you want us to do a deeper dive into any specific exam domains, drop a comment and let us know. Until next time, stay curious and study hard.